Hi, it's a pleasure to be with you at the Canadian Society of Echocardiography virtual meeting 2020. My name is Jonathan Afilalo, and I'll be speaking to you about multimodality imaging of dilated cardiomyopathy. You may have overheard the following phrases in your echo lab, and today we'll try to dive a little bit deeper to see how true or false these phrases are. Firstly, the LV is dilated, therefore the timing of this cardiomyopathy must be chronic. Secondly, the LV is dilated, therefore the etiology must be so-and-so. Thirdly, the LV is dilated, therefore the prognosis must be bad. And fourthly, the LV is dilated. So let's start with the last. How good are we at assessing whether LV is dilated in the echo lab? Well, as we know, we start with the basal diameter of the LV. This is based on the ellipsoid model, whereby we can estimate the volume of the LV cavity from this diameter. The problem is that the true diameter of the ellipsoid is actually more towards the middle of the LV. We looked at this in a research project whereby we took in a validation experiment using CMR and echo studies that were done close to each other. We measured both the basal and midventricular diameter on echo, and we then correlated that to the CMR volume from the method of discs. And again, we found that the echo measurement at the mid-level was more closely correlated to the CMR method of discs as compared to the traditional recommended basal linear dimension. When we measure with internal diameters, linear diameters, and compare to a reference standard, what often ends up happening is that normal or apparently normal internal diameters would be reclassified as actually being mild, moderately, or severely dilated LV cavities. And this is again in relation to LV end diastolic volume index. The opposite happens when we use non-indexed LV end diastolic volume. So here, simple Simpson's biplane, non-indexed, what happens? A lot of patients wrongly classified as severely dilated and then subsequently get reclassified to moderately, mildly, or not dilated at all. So from this nice study, we appreciate the importance of not only measuring a volume, but also indexing that volume to body surface area. And this is reflected in the guidelines that have cutoffs both for internal dimensions, but preferably for indexed LV volumes. And these 74-61 cutoffs look quite similar to this study where we had 72 and 62 in European males and women at a young age, 30 years of age. But what's interesting in this study is as we look at older ages, and these are normal healthy people at slightly older ages, we appreciate the significant downtrend in upper reference values for the LV and diastolic volume. So from 72 down to 66 for 50-year-olds, down to 61 for 70-year-olds. And the impact of race and ethnicity is just as marked, if not more. As we move from 70-year-old Europeans who have an upper reference value of 61 to 70-year-old South Asians who now have a upper reference value of 46, we can appreciate that there's a greater than 20% difference in the so-called upper reference value from one geographical location and ethnicity to the next. When we compare 2D and 3D assessment of LV volumes, one of the key messages is that with 3D methods, we can actually decrease our bias quite a bit compared to 2D methods. And here a 2D biplane had a bias of minus 50 milliliters on average compared to an MRI method of discs, whereas the 3D method cut that bias in half. And both of the 2D and 3D methods are quite reliable from inter and intra-observer points of view. But 3D can be 3D guided, or it could be 3D volumetric. And the volumetric relies on a volume of data or pyramid of data acquired through several cardiac cycles and stitched together. Whereas the 3D guided method relies on a series of two-dimensional images acquired during the same cardiac cycle with the probe positioned in one location. And in this study, when compared to the 2D biplane method, which was quite variable, as you can see, plus or minus 80 milliliters for end diastolic volume compared to a reference standard. That error was actually cut in half again by a 3D method, but the triplane method and the volumetric method were very, very similar and comparable, which leads us to recommend either or in terms of measuring a cardiac volume with 3D, either the triplane or the volumetric multiplane. If done correctly, both of these will do a lot of good to avoid foreshortening. And as we see here, foreshortening is when we're measuring the long axis of the ventricle in its not longest dimension. And this can have important effects on underestimating LV volumes. There's even been machine learning algorithms developed to help scanners in real time find that true apex, that non-foreshortened apex, and give them a green light to proceed to getting their 2, 3, and 4 chamber images. Another common mistake beyond foreshortening is actually undertracing. And this nice study from Moravi et al. Compared 3D echo volumes to CMR volumes in a multi-center setting. And they initially found a bias of minus 67 milliliters, where the 3D echo images were 67 mils smaller than the MR reference standard. When they dug deeper to find what the cause was, they found that the primary cause of this underestimation was the tracing. And what they did was they went back to their MRI images and they undertraced them in a way that they thought corresponded to what may have happened on the echoes. So as you can see here, they're tracing along the trabeculations, the loose myocardium, not along the compact myocardium as is being done correctly here in the lighter yellow. And when they did this dark orange tracing along the loose trabeculations, they actually got the identical or near identical volumes to their echo tracings, suggesting that this was really the dominant reason for the underestimation of LV volumes with 3D echo. If you can't see that compact myocardium, it's been well shown that giving contrast can help, and that can help define more clearly the compact myocardium and avoid being fooled by either trabeculations or pap muscles. And if we look at patients with good image quality, this doesn't have that much added value, but if we look at patients with poor or moderate image quality, it can have quite a bit of added value. Here, we're reducing the error from plus or minus 20% without contrast by half to plus or minus 10% with contrast. So certainly, if the image quality is not so good and we're having trouble seeing the compact myocardium, contrast could be of great help. What may also be of great help moving forward in the future is machine learning to better delineate and define these contours using computer vision. And here we have one such algorithm where it's been used to model not only the LV, but the LA, RA, and RV with volumes over time that can give quite useful information. So to summarize the recommendations for measuring LV size, the first recommendation is to use a 3D guided acquisition, either volumetric or simply 3D guided triplane. The second recommendation is to measure a volume, not just a linear dimension. The third recommendation is to trace along the compact myocardium and to use contrast if needed to visualize that compact myocardium. And this is while waiting for computer vision and machine learning to become routinely available and further help us in tracing along the correct lines. Fourthly, to index measurements to body surface area, and fifthly, to look at cutoffs specific to sex and maybe even to age and ethnicity, depending on the clinical context. So once we've defined our left ventricle to be dilated, we could then move on to look at the other criteria for a dilated cardiomyopathy. And here, according to the most recent definition of the European Society of Cardiology from 2008. So in addition to LV dilation, we look for LV systolic dysfunction, less than 40% ejection fraction. And we also importantly want to rule out coronary disease, hypertension, and valvular heart disease that would be sufficient to cause that degree of systolic dysfunction. We also want to rule out hypertrophic, restrictive, or arrhythmogenic cardiomyopathies that may look quite similar to a dilated cardiomyopathy when they're in their late or burnt out stage. So the approach could be as follows. So first, we would want to consider the non-dilated cardiomyopathy entities such as hypertrophic, restrictive, arrhythmogenic, unclassified, meaning non-compaction or Takotsubo, ischemic, valvular, hypertensive, congenital, and even athlete's heart. And we can then start exploring the differential diagnosis for dilated cardiomyopathy, which includes familial, toxic, infectious, immune, endocrine, and others. I'll note a few of these entities can actually present dilated even in their acute or subacute form. So dilation does not necessarily invoke chronicity in some of these cases, such as the toxic and the infectious myocarditis, as well as the giant cell myocarditis. As imagers, and specifically looking now at multimodality imaging, we're going to be concerned with ruling in a potential myocarditis or ruling out some of the other non-dilated cardiomyopathy entities, with the remainder of the entities and differentials being largely non-specific. So first, a word on late gadolinium enhancement, which will be key to achieve both of these aims. Gadolinium is an extracellular contrast agent that accumulates in areas of increased extracellular space or decreased vascular clearance. It's a little bit different in the case of an infarction, where our yellow gadolinium will essentially go in the area of the scar or replacement fibrosis. In inflammatory LGE, our yellow gadolinium is going to accumulate in these areas of inflammation and expanded extracellular space, and also decreased clearance. And this tends to produce LGE that's a little bit more patchy and sometimes faint compared to the infarction type of LGE. In addition to the appearance, the distribution is absolutely key. And the ischemic types of LG have very typical distributions in coronary territories that are subendocardial or transmural, whereas the non-ischemic forms will have mid-wall, subepicardial, or even global subendocardial hyperenhancement patterns. I'll point to this last global hyperenhancement pattern as being particularly specific for either amyloidosis or scleroderma. T1 mapping is also used routinely in CMR to identify on a pixel by pixel level whether the T1 time corresponds to something that may be fibrotic or fluid containing as compared to something that may be fat containing or iron. And there are a number of clinical entities along this spectrum from short to the very long T1 time. And the ones that I'd like to point out today are amyloidosis, which has a very long T1 mapping time. And as you can see here, these red interspersed pixels within the normal green myocardium. These are pixels of high T1 mapping time corresponding to interstitial fibrosis. And also at the other end of the spectrum, iron overload and Fabry's disease, which have very short T1 mapping times. And here we can see these blue short T1 pixels corresponding to fat-containing pixels in a patient with Fabry's disease. So this could be quite useful. If we put together T1 mapping and LGE, and we add in T2 mapping, we get to the updated Lake Louise criteria for myocarditis, which stipulate that if you have myocardial edema by a T2 technique, plus non-ischemic myocardial injury by either LGE or T1 mapping, then you've met your diagnostic criteria for myocarditis. Presence of pericardial effusion or systolic dysfunction further strengthen that. And Sarah Blissett with our group has looked at this in some detail to look at the individual criteria and really shown that the T1 and T2 mapping time added quite a bit of value in terms of diagnosis of myocarditis beyond the older criteria that did not include mapping times. Further than just the diagnosis of myocarditis, we can make important observations that lead us to better understand the prognosis of myocarditis. And in particular, this pattern of septal mid-wall LGE turns out to be the one associated with the highest risk of major adverse cardiac events in patients with myocarditis. And we can see an example here of a patient from our center that had exactly this pattern. Moreover, when we see lots of fibrosis, meaning lots of LGE, and little edema, then we worry that this patient is unlikely to recover in the subsequent months. Whereas, as shown by this study, when we see the opposite, meaning low fibrosis or low LGE coupled with high edema, well, then we assume that there's a high likelihood of reverse remodeling and that this patient may actually do quite well. LG has been looked at in many studies totaling more than 4,500 patients, and the message is quite clear. 45% of patients with dilated cardiomyopathy will have LGE in one form or another, and this is associated not only with MACE, but also with cardiovascular death, ventricular arrhythmia, readmission, and with a lower likelihood of reverse remodeling. Interestingly, in this study they looked at patients that had either preserved or minimally reduced ejection fraction with dilated cardiomyopathy, LGE turned out to identify a subset of these patients who otherwise would not have qualified for defibrillators that had a high likelihood of sudden cardiac death or aborted sudden cardiac death. And these patients were actually distributed fairly evenly among the low 40 ejection fractions to even the 50s ejection fractions, with a non-negligible risk of sudden death or aborted sudden death, even with these normal ejection fraction patients that had evidence of LGE. And this is really leading us to a paradigm shift where in the past we've used ejection fraction as the sole cutoff to inform risk stratification for sudden cardiac death and defibrillator placement. And as seen in the Danish trial, this turns out not to be the most discriminatory approach, because if we use this approach, we actually don't really achieve much of a mortality benefit at all with our defibrillators. As compared to our new paradigm, which may end up looking not at ejection fraction solely, but rather also at parameters like LGE, which represents scar and fibrosis as an arrhythmogenic substrate. And this is being actively looked at in the guided trial and other trials in groups of patients that have actually ejection fractions of 36 to 50 that would not otherwise qualify for a primary prevention ICD. An echo talk would not be complete without a word on strain, and strain has been looked at in dilated cardiomyopathy both in echo and in CMR modalities. And what we know is that, as in most other conditions, a low GLS confers a higher risk of mortality in patients with DCM. And interestingly, when we consider GLS and LGE into a prognostic model for mortality, they turn out to be the only two things that are predictive of mortality in 5-year follow-up. And things like ejection fraction and LV size, LV and diastolic volume index in this case, are not at all predictive. In the echo literature, one study here by Swat et al. Looked at strain low versus high in patients with dilated cardiomyopathies and found that the chances of reverse remodeling or recovery of LV systolic function were substantially reduced, and only 10% in patients that had reduced strain at baseline, whereas those that had better strain at baseline had a threefold increase in likelihood of reverse remodeling. So to summarize, 4 take-home points. Firstly, it's important to measure indexed LV volumes rather than linear dimensions, and to do so with a 3D method, carefully tracing the compact myocardium and not the loose trabeculations. Once we've identified a dilated dysfunctional heart, we could narrow down our differential diagnosis using ancillary echo findings and also, to a large extent, clinical history. We could use advanced imaging modalities such as CMR to further narrow down the differential diagnosis, and in particular benefiting from tissue characterization with T1, T2 mapping, and LGE. And finally, when determining whether a patient is at risk for bad outcomes, we should incorporate strain and LGE into our assessment to better predict survival and reverse remodeling. Thank you very much for your attention.